Welcome. My name is Dr. Kevin McGill. I'm a bariatric surgeon here at Piedmont Hospital in Atlanta, Georgia, and our goal today is to educate you about the disease of obesity and the available surgical solutions.
Hello, my name is Dr. Grace Lopez. I'm a bariatric surgeon here at Piedmont Atlanta Hospital. What makes our program unique is we truly believe in a multidisciplinary approach, integrating nutrition, in-office coordinators, and working closely with an obesity medicine specialist to help you along with your weight loss journey. We are fully accredited as a center of excellence with the Metabolic and Bariatric Surgery Quality Improvement Program. This helps us give you the best and most up-to-date care that we can provide. We also offer satellite clinics outside of the metro Atlanta area to help us reach out to those communities in need.
To begin the conversation, the first question we'd like to answer is, why do people choose surgery for their disease of obesity? For me, it really comes down to this first statement. Obesity is a disease, just like diabetes, just like high blood pressure, just like heart disease. Once you accept that simple statement, it makes the whole conversation a lot easier.
If you look at obesity as a chronic disease, number one, it has several implications. Number one, it's not the patient's fault. And I think that's very important. We want to remove any barrier to care, and we never judge or blame the patient.
For a long time, unfortunately, the disease of obesity was viewed as a cosmetic issue. It is not just a matter of eating less and moving more. There are multiple factors that predispose a patient to the disease of weight. These include genetic predispositions, behavioral predispositions, and metabolic and hormonal changes in the individual patient's metabolism. Sleep plays a role, stress plays a role. The foods we eat play a role independent of their caloric content, so that now we truly do appreciate obesity as a disease.
Now, it's the body fat that can hurt you a lot of different ways. One way it hurts you is it messes up your metabolism through something called insulin resistance, and that can lead to a higher rate of diabetes or premature heart disease. Through other metabolic processes, it raises the risk to at least 19 different cancers. And finally, it can have a psychosocial impact. It might lead to depression, social isolation, or decreased intimacy. And finally, there's just the body fat pushes on surrounding structures. We call this a fat mass physical force or physical effect, where it pushes on blood vessels and causes hypertension. It might cause strain on the heart. It might cause you to suffer from reflux. It might also cause sleep apnea, nerves to be pinched like carpal tunnel syndrome, and it might also lead to bones and joints to wear out. So it can affect us all very differently.
The obesity epidemic has increased in severity over the last 20 years. When we look at CDC data, we see that many states, a quarter of the population is considered overweight. Almost 300,000 deaths a year are directly attributable to weight-related illness, and we're spending a significant portion of our U.S. healthcare dollar annually on weight-related illness. When we look at some of the facts on treatment of obesity currently, medical treatment truly is ineffective for sustained weight loss in this very specific group of patients that we take care of, including those with a BMI bigger than 35 with associated medical comorbidities, or those with a BMI bigger than 40. Now, there are a number of FDA-approved drugs which are excellent tools in the fight against weight. However, they are not effective as primary standalone therapies for sustained weight loss in the morbidly obese population. This picture best summarizes the disease of obesity and the associated medical comorbidities. What I like best about this picture is that as you look from head to toe, you see that every system in the body is affected by weight-related illness. And what's nice, the folks at the Cleveland Clinic listed the percent resolution of those problems after metabolic surgery. Some of the ones that stand out on this slide are diseases such as cardiovascular risk, type 2 diabetes, hypertension, and respiratory illness. There are a host of medical problems on this picture that won't shorten your life, but sure make life uncomfortable as we live longer. Many of my patients suffer from joint and back disease. They're unable to receive definitive therapy until they lose a significant amount of weight.
So when do we start talking about weight loss surgery? We use two factors to determine whether or not you're a candidate for weight loss surgery. The first is BMI, or body mass index. This is a calculation of your weight and your height. While it's not specific, as it doesn't take body composition into account, it does give us a quick reference for whether or not you're a candidate for bariatric surgery. The other factors we take into account are your comorbidities. Do you have diabetes, sleep apnea, high blood pressure, high cholesterol? All of these play a role. If your body mass index is 35 or greater with a comorbidity associated with obesity, or if your body mass index is 40 or greater without, you're a candidate for bariatric surgery.
When should you have weight loss surgery or metabolic surgery? I do agree that this should be a last resort, but I've never sat with a patient who's never tried anything else. We must document your other attempts at weight loss over the years, and we'll go through a variety of medical support and clearances before proceeding with surgery. The process for weight loss surgery can be a little complicated. Most insurance companies will require a multidisciplinary evaluation. This is good basic medical care as well. Unfortunately, many of our patients have stepped away from the healthcare system. They're tired of hearing that they just need to eat less and move more. We use this as an opportunity to catch up. All men and women over the age of 50, their basic colonoscopies must be completed. We won't operate on tobacco users. Everyone's wearing their seatbelt. So as you see, we really use this as an opportunity to catch up on basic primary care.
Once you've completed the pre-approval process for bariatric surgery, you return to clinic and speak with one of the surgeons. There, we discuss the results of your tests, we discuss which surgery you've decided upon, and then we finally submit your file for insurance approval, which could potentially be one of the most frustrating aspects of this process.
Let's discuss the surgical options for weight loss today. Those are the laparoscopic or robotic adjustable gastric band, the Roux-en-Y gastric bypass, the biliopancreatic diversion with duodenal switch, or BPD, and lastly, the vertical sleeve gastrectomy.
We do our bariatric surgeries in a minimally invasive approach. This means smaller incisions for you and translates to hopefully less pain, a shorter hospital stay, and avoiding wound complications such as infections and hernias. We have the Vinci Robot here at Piedmont Atlanta Hospital. This is a tool that helps us perform our surgeries in a minimally invasive manner. It gives us 3D visualization of the surgical field, gives us a wide variety of instrumentation, and allows for us as surgeons to have precise control over our instruments.
How do these operations work? We focus on 3 basic concepts. Number 1, restriction. You're unable to consume a lot of food at any given time. In some way, shape, or form, we make the stomach smaller. Secondly, a metabolic or hormonal change. These operations not only limit the body's ability to consume food, but actually causes a hormonal change. These changes can affect how the body deals with calories consumed, can actually lead to immediate improvements in diseases such as diabetes. And lastly, lifestyle and behavioral change. The difference between these operations and a diet is that when you make a mistake, when you fall off the wagon, so to speak, you'll get feedback. If you make a poor food choice, if you eat too quickly, if you don't chew carefully enough, unfortunately, sometimes you may vomit, or sometimes you may experience abdominal discomfort.
In your research, you may have heard about the adjustable gastric band. While it's not commonly performed, it is worth mentioning. It's an adjustable band that's placed on the top of your stomach, which can be adjusted to be tighter around your stomach. This allows for more restriction. However, the band was not shown to have very successful, sustained weight loss, and it was also associated with mechanical complications associated with the band itself. One of the most commonly performed bariatric procedures is the Roux-en-Y gastric bypass. It works in 2 ways. It restricts how much you eat because we're making a small pouch out of your stomach. We're also bypassing a portion of your intestines, thus affecting how your body processes energy. It has been shown to be very effective in weight loss, with up to 60% of your excess weight lost. In addition, it has been shown to be very effective in diabetes. For those patients who have been diagnosed with type 2 diabetes for less than 10 years, there is a very high remission rate of up to about 80%. The surgery is an inpatient surgery that lasts about 2 to 3 hours. As we discussed, it has been shown to be very effective in diabetes, and additionally, we do recommend it for patients who have issues with reflux, as this can help resolve and improve them. What are some of the risks associated with the Roux-en-Y gastric bypass? As you can see here, there are many risks associated with surgery, but some of the ones that we focus on with this particular surgery are leak. Leak can occur at any of the connections that we make, either between the stomach and the small bowel or the small bowel and small bowel. If a leak occurs, this does require a reoperation. You may also experience issues with malabsorption and vitamin deficiencies, which is why we require you to take multivitamins for the rest of your life. It's when you don't take these multivitamins that we start running into issues. Additionally, for patients who have rapid weight loss, about 10% of patients will have issues with gallstones and may potentially need their gallbladder out.
The next operation we'll briefly discuss is the biliopancreatic diversion with duodenal switch. That's a mouthful. Most people hear this referred to as the BPD or the switch. Looking at the picture or the diagram, it is a bypass type operation. Rather than bypass a portion of the stomach, we've removed about 2/3 of the stomach, leaving a gastric pouch that some think looked like a shirt sleeve. This is where the sleeve nomenclature comes from. The second part of the operation involves bypassing a significant portion of the intestines. The advantages of this operation include it's the greatest potential weight loss operation, it has the greatest impact on diabetes. The disadvantages of this operation include it has the greatest potential for vitamin deficiencies, it has the highest early complication profile, such that it's not as commonly performed as the Roux-en-Y gastric bypass. The risks and complications of the biliopancreatic diversion with duodenal switch are very similar to the Roux-en-Y gastric bypass. The risks of leaks and vitamin deficiencies, as mentioned on the previous slide, are slightly greater than the Roux-en-Y gastric bypass.
The vertical sleeve gastrectomy has quickly become one of the most popular bariatric surgeries. It was born out of the biliopancreatic diversion or duodenal switch. The story behind that is when physicians found patients who were not able to tolerate such a long procedure, they split the procedure in half, starting with the sleeve gastrectomy portion of it. They very quickly found that patients were having sustained and effective weight loss and started doing this as a one-stage procedure. The sleeve gastrectomy lasts about an hour. It is slightly less complex than the Roux-en-Y gastric bypass, and as such, has a lower complication profile. The sleeve gastrectomy involves removing 2/3 of your stomach completely. The part of your stomach that's removed is thought to be the stretchiest part of your stomach. In addition, it is thought to produce the hormone ghrelin, which can affect your hunger and your satiety. Some of the risks associated with the sleeve gastrectomy are very similar to the risks associated with the biliopancreatic diversion and with the Roux-en-Y gastric bypass, in that when we take part of your stomach out, we leave a long staple line, which can be prone to leaks. Additionally, the removal of that 2/3 of your stomach is permanent. In the rare occasion that it is needed, we do also offer revisional surgery, which is reviewed on a case-by-case basis.
Let's discuss the post-operative course after metabolic surgery. Most patients will spend 1 to 2 nights in the hospital after surgery. There is a slow diet progression that entails 2 weeks of a liquid diet, including protein shakes, 2 weeks of soft pureed type foods, and about a month after surgery, we slowly introduce regular food. Your relationship with food will dramatically change. I can say that in a quick sentence, but it may take months to fully realize that. Meals are smaller and more frequent throughout the day. Patients learn to chew their food carefully and learn to eat very slowly. Behaviors such as separating solids from liquids must be learned and take time.
We also offer support groups and cooking classes, as we understand that this is more than just surgery, it's a life change.
Exercise must become a daily part of your life. Many of my patients are already very active despite their weight. Many of my patients can't walk without assistance. So how we accomplish this varies from patient to patient. There are many factors that play a role in which surgery is ultimately right for you. We'll look at your age, your body mass index, your individual medical history. I'll give you a recommendation in terms of what I think is right for you, but oftentimes it will come down to personal choice.
Thank you so much for joining us today. We understand this is a difficult, challenging, and emotional decision to move forward, but we want to be with you every step of the way. If you want to learn more, our office will contact you within 3 to 5 business days. I always tell my patients, it's just a conversation. It's never a commitment. We're just here to learn more.